I'll request Dr. Pranav SALUJA to give his talk. Dr. Pranav SALUJA is from Prayagraj. He is working in Center for Sight. He was previously in Regional Institute of Ophthalmology, MLN Medical College, Allahabad. So, Dr. Pranav, please.
Thank you, sir. At the outset, I would like to thank Professor Kamaljeet, sir, and respected seniors for giving me this opportunity. So, I'll be talking about SICS on astigmatism. So, as we all know that there has been technological advances in ophthalmology, and it has grown by leaps and bounds. And it is not only our job to improve the patient's vision, but also to refine it. And proper management of astigmatism can lead to excellent visual outcomes. So to achieve emetropia is the target nowadays, and the goals are mainly painless visual recovery, spectacle independence, correction of pre-existing astigmatism, and repeatability of the surgical result with a sustained quality of vision. So just going on to the basics, the types of astigmatism, as we all know, is with the rule and against the rule. And against the rule is the one which is more common in the older patients, which is the cataract patients. And so it is better to make the incision towards the temporal so that the astigmatism is controlled. So the factors affecting astigmatism is mainly incision characteristics, the use of cautery, and the use and non-use of sutures. There are other multiple factors which we'll see later on. So how do we measure this astigmatism? It is mainly with the help of retinoscopy, keratometry, and corneal topography. And we can use a manual keratometer, which is preferred in patients with poor fixation or if there is corneal abnormalities, distorted Meyers, and a highly toric cornea or a dry cornea. In rest of the cases, we usually do a topography. So how do we correct this astigmatism with SICS, which is the topic for today? So the main thing is the incision characteristics. So as we all know, if the size is larger, there is greater flattening, and if the size is smaller, then there is lesser flattening. The distance from the cornea is also important. The farther the incision from the cornea, the lesser the astigmatism, and vice versa. And the configuration is another thing which is important. It is always good to target and hit the astigmatically neutral zone. So what is the astigmatically neutral zone? This was described by Koch, and he described that surgically induced astigmatism was inversely related to the distance of the incision from the corneal center. And the funnel's base is at the limbus, which is here, and it moves away as it widens. The incision which is made within the funnel is usually astigmatically neutral. So if we make it the incision here near the limbus and it is in this zone, then the astigmatism will be almost zero. And if we make it farther from the cornea, then we can also make a larger incision and then also have a astigmatically neutral zone. So this induces almost 0.25 to 0.5 diopter of astigmatism only. So the other thing is incision type. Superior incision has been found to have more chances of astigmatism, and although it is easy to learn and we usually learn during our residency, but temporal incision is the one which is better for treating the astigmatism, and also in cases where there is deeper sockets, smaller eyes, or future trabeculectomy is considered. So this is the concept of coupling, which suggests that the flattening effect is achieved at the tissue and the steepening is produced 90 degrees away. And surgically induced astigmatism is almost -1 to -1.5 diopter at 90 degree if a 6.5 millimeter incision is placed. So again, when we flatten one meridian of the cornea, we steepen the other meridian. So it has been studied in various studies, and it has been found that superiotemporal or temporal incision is the one which should be considered if we want to correct the astigmatism. And the incision length, as we talked about, the larger the incision, the more the chances of astigmatism. So excessive cautery also increases in astigmatism, although me as per do not use cautery during SICS. But in cases where we use cautery, there can be scleral shrinkage and scleral necrosis and lead to astigmatism. So how do we correct this astigmatism? Mainly in mild astigmatism, it is just neutralized by changing the site of the incision. So if we operate on the steeper axis, then mostly the astigmatism is controlled, and we can vary the construction according to the astigmatism that we see on the topography. So limbal relaxing incision, this is another thing With a 90% depth and a steeper meridian in front of the limbus, we make the incision just in front of the limbus and at a 90% depth to correct the astigmatism. There are pre-existing guard blades which are present. This is a video showing astigmatism. We make a incision and then make a tunnel, but we do not enter the anterior chamber. After this, we mark it according to the amount of astigmatism that we want to correct. Usually a 30-degree or a 60-degree incision has to be made and just made in front of the limbus at a 90% depth. So this is a guarded blade which can be bought from anywhere, and this corrects the amount of astigmatism whichever according to the calculator we have calculated. So it is imperative to check the calculation to prevent any mishap, and a 90-degree off is the most common error. And again, operating on the steeper axis is what we have to do. So there are various normograms which are given. There is Miller, Gill and Nickerman, which can be helpful. And there is also an online calculator, which is lricalculator.com, with the help of which we can correct the amount of astigmatism that we want to correct. So again, these are the details and multiple of normograms which have been given by Gill, and the amount of astigmatism that can be corrected. So the advantages in this is there is less tendency of shift to the resultant cylindrical axis. There is less chances of irregular corneal flattening and irregular astigmatism, which is in case of an arcuate incisions. And it is easier to perform than a shorter and centrally placed corneal relaxing incision. And also, as we've already talked about the coupling, it gives a 1:1 coupling ratio. So there is less amount of chances that the astigmatism won't be corrected. Then this is another thing, if you want to correct a higher amount of astigmatism, usually a opposite clear corneal incision is given. This was described by Lever and Dahan, and the mean astigmatism correction achieved with this technique was around 1.66 plus minus 0.5. So this technique involves creating two biplanar incision, which is 3.2 millimeter on the steeper axis again. And although there is lack of predictability and absence of nomogram, but this also corrects around 1.5 diopter of astigmatism. So this is a flowchart depicting what we've already talked about. If there is a lower amount of astigmatism, 1 diopter, we can just put the incision on the astigmatically neutral zone so that the astigmatism is very minimal. And moderate, in cases of moderate, we can put a small incision, make a straighter incision so that the astigmatism is corrected more. And if we want to correct a higher grade of astigmatism, then usually a combination of the limbal relaxing incision and the incision profile is needed. If it is post-operative, then astigmatic keratotomy can be done, a wound revision can be done, and even a laser can be done in these cases. So take home is that first of all, a pre-op and intra-op identification of the astigmatism should be done. And as we've already talked about, a step-ladder approach should be done according to the amount of astigmatism that is present. And technique can be effectively combined for higher levels of astigmatism. And again, always apply the incision on the steeper axis. Thank you.